Dear colleagues, dear Felix, dear Lothar Schmitz, dear Dr. Owrudzki, thank you very much for the invitation to this meeting. It's a great pleasure for me to be here and as an obstetrician and head of the ultrasound division of the charity hospital, and I want to thank especially the team from Professor Berger for the nearly now 18 years fruitful cooperation, and to have a German heart center with pediatric cardiology and pediatric cardiologic surgery and the biggest obstetrical department of Germany on one campus is a really comfortable situation to treat these critical patients adequately. So when you do prenatal diagnosis or prenatal examinations, you have to take into account the size of the fetal heart. As you can see here, a wonderful specimen from Dr. Zarioglu from the charity pathological department with 13 weeks. And you can imagine that it might be sometimes difficult to explain parents about the diagnostic accuracy of fetal heart defect, especially in this minimized version of a fetal heart. And if you know this old German currency, you can see with 19 weeks, the typical second trimester screening, we have a size of just 1 Pfennig size, the old currency, and when you go then with 23 weeks, it's just this size. So you can imagine how difficult it is sometimes, especially in the more and more obese patients we have to treat with to make exact prenatal diagnosis. On the other hand, we see that there are developments. Could you reduce the light, please, in the room? This would be great, because I have a lot of, and also perhaps this one. I don't know if we need that. Anyway, what I want to show you with these 3 images or video clips is that we have another problem. One is the size, the examination conditions, and the third is that we have development of fetal cardiac defects, like you can see here in 16-week patients, patient who develops from 16 weeks to 30 weeks hypoplastic left heart syndrome. And this will be actually the next topic from Dr. Tulsa, and I'm very excited to see if interventions really can improve the outcome, and accordingly to the small size of the fetal heart, we will learn and hear a lot about the technical problems and about the fetal intervention and the intrauterine valvoplasty. But what definitely is proven in benefit is that the prenatal diagnosis influence the pregnancy outcome and the outcome of the newborn, and this is shown in several studies, and also in one of our studies at the hospital, at the charity, where we were able to show that prenatal diagnosis of isolated congenital heart defects allowed admission for surgery in a more stable condition, and it is associated with lower short-term and long-term morbidity and mortality. And this was definitely shown in already all the severe diseases which are duct-dependent, like coarctation, hypoplastic left heart syndrome, the transposition of the great arteries, and this intrauterine transport into an obstetrical department with a definite repair on the same campus is of a huge benefit for these intrauterine patients. So we have, from the International Society of Ultrasound, Obstetrics and Gynecology, pretty good guidelines, and the good news for the patients is that we can reassure them in more than really 99% that they don't have a patient or an unborn with a cardiac anomaly. And this is very important, especially we have more and more patients which are by themselves already operated or treated by congenital heart defects, and they have an increased probability that their unborn will have also a cardiac defect. So the reassurance of a normal finding is of extreme importance. On the other hand, these guidelines gives us really simple recipe how to examine the fetus, and the detection rates are pretty good when you go above the four-chamber view examinations. Four-chamber view examination actually has a detection rate of cardiac anomalies in about 30%, but when you perform a more extended basic exam, which goes further of the four-chamber view into the great arteries, you can detect 60%, and the expert scan, the really fetal echocardiography, can nowadays detect more than 90% at least of the relevant cardiac defects. And we are here in Berlin in a very, very comfortable situation that we have a lot of experts now. Went unfortunately out of the university hospitals into private practice. Anyway, we have a very high proportion of patients of these 30,000 pregnant women yearly in Germany, in Berlin. The most of them are really nowadays screened by an expert, and so we have an extremely high detection rate, nearly more than 90%, especially of the relevant problems. So, how to perform it prenatally is actually relatively easy when you have good examination conditions. You see that the fetus is a posterior position. You have all tiny women, and the belly of the baby is very near to the uterine wall. And in this situation, you can easily perform the fetal echocardiography, and you need just actually, as an expert, a couple of seconds to visualize at least across malformation. And this is the first view actually we try to access. You see the gallbladder, the stomach, and the umbilical vein, and the heart in the right position. And the advantage for the prenatal sonography is that the heart is actually in a horizontal transverse position due to the lack of air in the lung and the relatively high diaphragm. So we have a pretty good view into this four-chamber view. And you see, you need only a couple of seconds to see that this is the left ventricle, the right atrium, the left atrium, and the pulmonary veins are coming in the foramen ovally, and you can see wonderful the relatively same size of the ventricles, a slightly wider right ventricle actually prenatally, and I will come a little bit later on to this point actually. In the next view you see the five-chamber view. Actually it is not the five chambers, but you can visualize the outflow tract of the left ventricle. You can wonderfully see the aortic valve, and then the pulmonary valve, and how these great vessels are crossing. This is a very, very important, just 1 to 2 millimeters you go upwards from the five-chamber view in the three-vessel view, and you can visualize this important crossing of the great arteries and then the bifurcation of the pulmonary arteries. And the continuous septum here are absolutely normal, regular, wonderful fetal heart, and you use also the color Doppler to see the inflow into the both ventricles, that you have a wonderful mitral and tricuspid inflow, and then again also the crossing of the great arteries. Sometimes a little bit more difficult is the sagittal view to visualize the aortic arc, and we'll come a little bit later also especially to this point. But it is normally you can achieve this also in the routine scan. You have to differentiate between the aortic arc from the ductal arc. And this is already sometimes a little bit difficult for the beginner to differentiate these two arcs, because they do not expect such a huge diameter of the ductal arc actually, because it's already, when you see neonatal books or cardiology postnatal books, the arterial duct is already very, very tiny shown, but in the prenatal time you have really a wide diameter, as wide as the aorta in the arterial duct. So also we can visualize the pulmonary veins here. draining the blood into the left atrium pretty good. And here, finally, also, again, the four-chamber view crossing of the arteries. You can see pulmonary artery, aortic arc in the transverse area. You can also visualize the left vena cava superior here, and the trachea is visible also easily. So this is at least as important to show this three-vessel view in the routine scan, because you can detect definitely all the critical duct-dependent congenital heart defects. Here again, the discrimination in the sagittal view from the aortic arc. It is a small angle here, and then the wide angle here from the ductal arc to differentiate in the sagittal view. Now, more advanced and fancy techniques we also have in the prenatal diagnosis and in our machines. Now we can visualize actually on one screen the four-chamber view, the aortic root, and going upwards the crossing of the pulmonary artery, aortic artery, the vena cava superior, and the trachea in one actually image. So we looked actually in the time between 1993 to 2004 about our accuracy at the Charity Hospital, and what we actually found that we totally confirmed our prenatal diagnosis in relation to the postnatal diagnosis in more than 90%. And interestingly, we looked then, what about the 7% we missed or we misdiagnosed? And the interesting thing is that all were, or the most of them were related to coarctation of the aorta, though it means we had a false positive rate on one hand, or on the other hand, we missed some of the cases. I will show you in a couple of minutes. So this is one of the biggest problem actually, is the definitely diagnosis of coarctation, because there is the development and the closure of the arterial duct which influence the isthmus of the aorta postnatally, and which we have really troubles to predict before. So we will talk in the next minutes about this area here, about the aortic valve on one side and the accuracy of the diagnosis, and I show you some spectacular cases, actually especially one case we treated together with Professor Berger, and we will talk about the aortic arc. So this was one case, and I choose that case because it's so interesting, because we have now a more than 12, 13 year follow-up in that case, and that was the reason I chose that one. We already also published that in the White Journal. It was a patient, his name was Justin, and the lady came in. She was a non-risk patient, 22 years without any anamnestic risk or history of cardiac anomalies in the history or in the family, and she came in with a fetal hydrops. And it was easily to detect this left ventricle here with the endocardial fibroelastosis, and you can see how the blood is here turning around in the left ventricle and going back into the left atrium, and the reason for that was actually this critical stenosis. And we sent that video clip to several colleagues and several experts and asked them, what do you think about the prognosis and what would you do now? It was actually in the 90s or around 2000, something like that. So the interesting thing is, most of them said the baby will die. And you have no chance to treat that prenatally, you have no chance to bring it now out within 2 weeks, it's already in a very bad condition. So what we did in that situation, we do interdisciplinary counseling. This is very important, that you bring together the neonatologist. Not all of them are as bright as her. You have to call the pediatric cardiologist, and then you demonstrate the finding, and then you counsel with one tongue. It is not recommended to send her to a cardiologist, he's saying something, then you send her to the obstetrician, he's saying something, then you send to the neonatologist, and then to the psychologist. Bring the people together and try to counsel them with one tongue. This is very important, because otherwise you get different opinions. And this is now the video from Professor Berger. He sent it me just yesterday, actually, because I found that case yesterday, and he was immediately available. I was really impressed that you needed only 1 day to send me to find this case. It was already more than 12, 13 years ago. And he sent me here the video clips from the postnatal course. So, but I forgot to say, we administered digoxin to this patient. And interestingly, the fetal hydrops resolved totally. We had a relief of the fetal hydrops, and we had a really improvement of the cardiac function. And then with 35 weeks, we delivered the baby, and Professor Berger performed immediately in between the first hour the intervention here with the balloon valvuloplasty, postnatally balloon valvuloplasty, and you can see the result, a pretty good result, immediately after the successful valvuloplasty. So, and then I asked him, what about the patients now? And he said, with 9 years, he had a wonderful clip about the cardiac function, and you see that here, 9 years later. And this was the imaging of the echocardiography. You can interpret this much better than me in the postnatal phase, and then here also the valve. So Professor Berger told me yesterday that 2 years ago the baby needed then an operation in the area of the valve. Do you know what are they? Huh? 12 years. With 12 years. And what type of operation? A Ross operation. Okay. So anyway, Justin is doing pretty well, and I think it was a really long-term success, and we published that case in the White Journal. No, not all of these cases are so critical and so traumatical. This is also another case with a aortic stenosis, and you can see that the left ventricle and the right ventricle are doing pretty well. It's a little bit dilated here, left ventricle, and you can easily see in the 5-chamber view this valve here, which looks very hyper-echogenic, and it's opening not in the correct way. And using the color Doppler, you see turbulences across the valve, and an increased velocity, more than 2 meters at least, is typical for a significant stenosis. The mild stenosis you might miss because they are really very difficult to diagnose. We know that 80% are valvular, 15% are subvalvular. You have to take into account that diabetes patients have an increased risk for subvalvular stenosis, and supravalvular stenosis have not been prenatally, so far I know, diagnosed or published. In the enfance view, you can see here now this bicuspid hyperechogenic valve. So these cases also are possible to diagnose, and we have measurements from Shapiro when we have the suspicious situation for a aortic stenosis. We can go to Shapiro curve and see if the diameter of the aortic root is in the normal range, and if you have to expect and you can stenosis, and we can follow up this area in recurrent examinations. But you can see as here, this is a patient, we were not really sure. We had wonderful 4-chamber view. We have some turbulences here across the aorta. The diameter is pretty good, about 5-6 millimeters, and there is an increased velocity about 175 centimeters, and we were not even sure what will come out of it. And definitely this mild stenosis with mild increase of the velocity showed postnatally a relevant aortic stenosis. So we looked to our own series now from the last 10 years, and we found 44 prenatal cases, and postnatally 75% were correct diagnosed, and we had 25% false positive. Unfortunately, I have no exact numbers now how many we missed actually. This is difficult to find actually these numbers. But anyway, as it is the same with the coarctation, you will have some confusing confused patients due to false positive suspicious situation prenatally, which is not confirmed postnatally. Anyway, the really critical stenosis are pretty easy to diagnose. We showed it in this case with Justin. On the other hand, this mild stenosis, they might just have a thickened aortic valve, some antegrade turbulence, but because of the normal size, contractility, echogenicity, and the antegrade flow into the left ventricle and the regular right to left shunt, you will miss, I think, prenatal, and we will miss a lot of these cases with mild aortic stenosis. However, it is not so relevant actually, and hopefully the neonatology will detect these cases by routine auscultation, listening to the fetal murmur, to the heart murmurs, to rule out also these patients. From the prenatal view, two further aspects are actually important. That in 20% we have ventricular septum defects. It is associated with the coarctation when you have the aortic stenosis, and we have to rule out also the Williams-Beuren syndrome, which is a microdeletion and possible to diagnose prenatally out of amnion fluid. Now let's come to the second topic, much more difficult actually, the coarctation from the prenatal point of view. Also here, look at this wonderful specimen from Dr. Zarioglu. She is able to find this situation or this pathology already in the size of a baby with 13 weeks gestation. So coarctation, the typical key presentation is the discrepancy of the both ventricles. And you can obviously, without measurements, see that here the right ventricle is much larger than the left ventricle. And this gives you already the first hint to look more in detail to the aortic arc. Here the valve of the aorta or aortic valve is absolutely normal, but then coming into the three-vessel view, you easily can see a hypoplasia of the aortic arc and also a retrograde or retrograde perfusion of the transverse part of the aorta. So we have to see that 5% of the congenital heart defects have a coarctation, and that the best way to differentiate it is, or to see it, to have the suspicion for that, is to compare the ventricle sizes. And this is already published, that the discrepancy of the chambers, the disproportion of the chambers, is the key to diagnose this malformation. And here, in comparison, a normal pulmonary trunk, a normal aorta, a normal aortic arc, and a ratio of 1 between the arterial duct and the isthmic of the aorta nearly rules out an aortic coarctation. So the ratio of 1 is very important here in comparison, and we do not measure it in the routine scan. We just also go into this diagnosis by just the impression, the view, how it looks like actually, and then the size of the ventricles. So we have from Shapiro learned that the ventricles, the left ventricle and the right ventricle with 21 weeks is nearly the same size. And there is a little bit increase at term for the right ventricle. There is a slightly discrepancy between both ventricles. However, if the left ventricle is more than 1.7, the factor 1.7 smaller, then you have to take into account that it could be due to coarctation. But look at this case. It was a prenatal case. Now I know already the result, the postnatal result. Nearly same size, 9.3, 9.5, with around 32 weeks. Wonderful inflow. But then when you look here to the three-vessel view, you have here a diameter of 3.5 and a little bit narrow, a little bit more narrow than the duct. So also visible here in the color Doppler. So we were not really sure how to manage this patient postnatally. And we said, okay, you have to deliver in tertiary center. We will perform in the first hours after the delivery an early echocardiography, and we'll look how the duct and the aorta will react, how the blood pressure is in the lower extremities and the oxygenation and so on. So, and actually I expected in that case that she might not need an operation, but unfortunately the isthmic became narrowed after the delivery, and the patient had to be operated. And you can see a follow-up with 4 weeks later. It was 37 weeks. You can see here again nearly 4.7 millimeters, nicely narrowed here a little bit, antegrad flow, and in the sagittal view you can see the aortic arc and here the white duct. So the discrepancy between a ratio in advantage to the duct is suspicious for the onset of a relevant stenosis. And we have also normal values for the great arteries, and you can see here it's the same like in the ventricles. The aorta is a slightly smaller, the aortic root, and the pulmonary artery is a little bit bigger. This is due to the physiological fact that in the prenatal phase we have 60% of the fetal blood is going through the right ventricle into the pulmonary artery, 10% each to both pulmonary arteries and 40% to the arterial duct. And the rest of the 40% going to the left ventricle, going into the aorta. And this makes clear from the physiological point that the aortic arc and the duct should have the same size, and the ratio is 1:1 when you compare these two parts of vessels. This is the current case. I just saw her a couple of days ago, and you can see here a significant discrepancy between the both ventricles. And in the transverse part here of the aortic arc is a little bit narrowed. It's about 3 millimeters here. The arterial duct is a little bit wider. And in the sagittal view, you can see also this small narrowing part here. So actually, it's a little bit the same like the case before. We hope that it will be wide enough, but we cannot really predict if it will become narrowed further in the postnatal phase. But we are aware of the problem, and we are prepared to react adequately with keeping the duct open. So we also looked to the last 10 years about the accuracy of our prenatal diagnosis, and we had 107 prenatal cases, also 78% correct diagnosis, in 22% false positives. This is not very good. I mean, this is really a problem. You confuse the patients, and then they go to the neonatologist, they make an echocardiography with the cardiologist, and they say everything is fine, you can leave the hospital. And then they say, oh, they confused me definitely in the prenatal division. Anyway, it is very, very difficult to predict it in 100%. So here again, some interesting publications about the topic. Here, the most important essential out of this is that here the width of the duct is 1:1 in the isthmic area. So to rule out these findings, and I will just show you this interesting imaging from another publication showing that this shelf here in the area of the isthmus also is a pretty good indicator, like turbulence flow, post-stenotic, wide descending aorta, and the width at itself of the isthmus are pretty good predictors. So my last slides are according to the really actually relatively easy diagnosis of the hypoplastic left heart syndrome. You can easily detect this in the four-chamber view already. You have only an inflow in the right ventricle, a mitral atresia here in this case. Also the power Doppler shows you absolutely a lack of flow into the left ventricle, and then the discrepancy of the flow, so the white pulmonary artery and the extremely narrowed retrograde perfusion of the aortic, of the hypoplastic aorta, according to the atresia of the aorta. These cases are actually relatively simple to diagnose. It is much more important how to treat that patient, because you have to offer them the termination of pregnancy. You have to offer them just hopefully a spontaneous normal delivery, and then to give them a chance to refuse any type of correction or intervention, and then you can also start with the full operative treatment, and you know much better than me the results and the long-term effects of this disease. So this hypoplastic left heart syndrome, to differentiate from coarctation, is from the prenatal point of view also very, very easily, and I don't want to go too much here in details to the different parameters. So I will try to summarize a little bit and give you perhaps a chance for one or two questions. First of all, I think it is very important that with prenatal diagnosis, with fetal echocardiography in the expert hand, you can nowadays, and this is a little bit in discrepancy to the published data so far, in experience hand you can definitely detect more than 90% of at least the relevant malformations. The second thing is you can reassure patients who are at higher risk, diabetes, previous baby with a heart defect, or the familiar problems and the history of the patients actually. So on the other hand, you can see this already sometimes with 13 weeks, but I would be very, very cautious in this size of the baby's fetal heart to rule out aortic stenosis and coarctation like that. You can, perhaps univentricular heart, you can see pretty good, but the typical second trimester screening with 22 weeks is the best way to rule out these malformations. We have still the problem that mild stenosis of the aorta, mild stenosis of the pulmonary artery, and the coarctations, they are sometimes missed, still missed, and we have a relatively high false positive rate, which might confuse our patients. On the other hand, the knowledge about that, the transfer, the intrauterine transfer in an obstetrical department with a heart center on the same campus is absolutely recommended and reduce morbidity and mortality in this field. And I'm looking very much forward to now Dr. Tulsa's talk about the intrauterine inventions, and keep in mind the small size of the fetal hearts, and I appreciate that he's here, and I think he's one of the world experts with Dr. Arzt and Professor Twaretsky from Boston's group, and I'm very looking forward to your presentation about your results. And so far, I would like to answer also one or two questions if you would like to ask me. Thank you very much for the attention.